Hi, it's my pleasure to welcome you to today's webinar, which will explore the growing field of AI and its influence on transplantation. It brings together a panel of internationally recognized experts who will share their perspectives, the latest evidence, and practical experience. My name is Dr. Jen Lee, and I'm a transplant nephrologist at Westmead Hospital and co-chair of the TTS Education Committee. Joining me is Dr. Harry Robertson, my co-moderator, who is a postdoctoral research fellow with strong interest in AI digital pathology at Westmead Hospital and the University of Sydney. I'd like to mention a few housekeeping items. This webinar is recorded and will be available on the TTS webinar library following this event. And throughout today's session, please submit your questions in the Q&A box or Q&A function. And we encourage you to send questions throughout the presentation at any time, and we'll try to answer as many as we can. And I'll hand over to Dr. Robertson now to introduce our first speaker.
So our first speaker for today's webinar is Dr. Artem Trotsyuk. He's an AI research fellow at Stanford University. Artem earned his PhD in bioengineering and a master's in computer science with AI specialization at Stanford. I was reading about this. His doctoral research focused on developing a smart bandage, which sounds really cool. It integrates a closed-loop AI processing system for wound sensing and therapy delivery. His current work centers on evaluating AI tools in biomedicine, as well as special projects related to security, intent capture, and persona modeling. And so to kind of give us a bit of an introduction to today's webinar and set the scenes, I'd like to hand over to Dr. Trotsyuk. Thank you so much.
Thank you again for having me, Harry. Thank you so much for the kind of introduction. So I'm excited to tell you a little bit more today about the work that I'm working on that would be relevant to this group, and kind of tie it together to all the work that I've done previously, and leave you guys with some thoughts to think about as you consider AI tools in clinical deployment. So by way of background and introduction, just building on what Harry had mentioned, I've worn a few hats. The first hat that I've worn has been on the side of building these models. So during my PhD time, I developed this closed-loop smart bandage. What that entails is looking at using big data to identify what are the key parameters that would be indicative of a wound healing over time, and if we can use sensors as by way of proxy to determine and help a patient recover better. So typical wound care right now does not allow for your monitoring in between visits of a doctor. And so we thought that if we used a bandage that had some sort of sensing technology, we can at least help patients in between visits alert to when a wound would be infected and would have or had an incoming infection. And that was interesting to see that we can pull that information out of the data and predict a infection of a wound about 48 hours before it actually became a clinical incident. So when in doing that work, I got super interested in what it took to develop these models, particularly if you're talking about things in the space of AI machine deep learning, and now foundational models are much more the hype now, generative AI, world models, all these different classifiers of terms all tie into how do all these models perform in the real world, and how do we evaluate them? So I then transitioned to doing work on evaluating the models, particularly in industry, and helping to understand better how can we get expert feedback into the loop of these model outputs. That way we can actually have accuracy and accurate understandings of and not hallucinations of when you ask a model question, the output itself is more appropriately skewed towards what it should say. Then I realized that there is a big gap in broadly identifying how we can evaluate these models for a healthcare system. And with that, for the rest of the talk today, I wanted to highlight some of the work that I'm doing with Heal AI, where we run ethical assessments on AI tools proposed for use in Stanford healthcare before they are deployed, to inform the key decision stakeholders on how we some of the things that people should think about before turning on a model. So let me premise this by showing you guys how this all fits together. So as the way that we look at evaluating a model at Stanford is by using the FIRM framework. FIRM stands for Fair Use Reliable Models. This framework was set out back in 2025, and it has a number of key metrics. Of it, we look at things like what's the usefulness of a model, what is the financial sustainability of this model, how can it have a certain will it be or there'll be a return on costs that we're spending to deploy these models. What about monitoring, or what is the proposers team deployment strategy on whether we can have the how are they planning on rolling it out? Is it a pilot? Is it not a pilot? Is there feasibility of even being able to support this model on the back end in the clinical setting? And then finally, which I'm mostly involved with, is the ethical review of what are the values, or what are the value collisions that we are not servicing just by looking at the code or looking at spreadsheets or deployment strategies that would be useful for the leadership to consider before deciding if they want to turn on or turn off a model. So what that entails is in our kind of broke it down into 4 sections. The first is the process by which we do an intake. An intake is discussing with the proposing team what is the what are you working on? What is the model? What are you doing? Then in getting all the questions, kind of your initial input questions answered, we then start talking to stakeholders. We want to understand truly in this process, what is it that the stakeholders are not, what are their values? What are the important points that they view in a model and the model's output and the model's impact on workflow that might not be surfaced in just a briefing? Then we have a group of experts, usually faculty or other folks who are experts in ethics and there's different domain experts in their field review our findings, and then we share those findings with leadership. Usually this lasts about 30 days, the entire process. You don't need a ML degree to do it. A small team can really execute on this. We are currently developing a playbook to allow for folks to just take this process and scale it to other institutions. But I wanted to kind of highlight the number 2, the stakeholder interviews component. So the personas that we're looking at, and they kind of fall into the buckets, put these 3 categories here. Sometimes you'll have other types of personas that show up, but you'll have typically your proposing team or your developer team and the folks who are looking at putting together the model, developing the model. You'll have an IT person there. You'll have someone who's more tied into the building and deployment of said models. You'll also have your clinical personas. So these are either your nurses or your back office folks who are using the tools, if it's a back office support tool, or if it's a patient-facing tool, you'll have more maybe actually the actual physicians, wide range of folks who are actually using the tools. And then finally, what we add to this entire process, I think it's super important, is getting a patient perspective. So often we deploy the models without thinking about what is it the patients actually care and consider when turning on a model. And we have, so we've put together a standing patient partner panel of patients across various age, various demographics. And their perspectives are pretty interesting to bring to the table when you think about turning on an AI tool. So the objective here is really, we're not really trying to find consensus and where everyone agrees. We're actually looking for the disagreements and the discussions with these various personas, because then you really understand what are the gaps that these tools may or may not be addressing. And the ultimate goal is for us to make sure that we are benefiting patient care. So I'll give you an example of a use case, an ambient scribe use case. I'm sure many have either interacted with or have used or have heard about an ambient scribe tool. So I wanted to bring kind of the two sides of this to show to explain a little bit more about how our process the outputs of a process. So typically, if you're looking at an AI scribe tool, if you have a company that's trying to sell or integrate this tool into your clinic, they might say they'll have a certain amount of hours saved. You'll have the clinician still is involved in the loop. There's less documentation burnout. It's just transcription. It's not high risk, so forth. Now, what we found with looking at these types of tools when we talk to these different personas is that the time spent or saved is sometimes not there, or if it is saved, what is it spent on? And the questions that come up with that. Now, the other part is that this note, the note that is generated by a scribe, if it's not reviewed well by the person who's using a tool, that note then goes into the care continuum and is permanently in the patient's record, and it will drive the next decision, including referrals, billing, and so forth. It's super important. It's not so we consider less than low risk when you're talking about the impacts on potentially an error in the patient's chart. And then the other question that came up quite often when talking about these ambient scribes is consent, and whether or not we do need to inform patients about the consent on whether if they're okay with using tools like this or other tools in general, and just asking them about what their thoughts are of that. So the kind of the higher level 30,000-foot view is that there is a ton more models than our capacity to evaluate these models. And we're adopting AI tools much faster than we can evaluate them. And so how do we develop resources and infrastructure to really help surface the tensions and surface these workflow impacts that may not initially be visible and or seen when you're thinking about turning on a tool? And really and the components of this include like thinking about how do we engage these multiple stakeholders? What are those evaluation methods that could be relevant to folks who are actually deploying these and actually testing environments that are more practical? And then highlighting here some things that my colleague Michelle Mell has highlighted before, of having more of a national data infrastructure and better regulatory incentives to help folks develop models that have evaluation capacity. And so I'll leave you today with these two buckets of resources you can look at. The first was Heal AI, the work that we're currently doing at Stanford, particularly on the ethics evals. As I mentioned, we are developing a playbook and a video series that will be launched by the end of summer that folks can tune into and see us walk you through the stages that I mentioned earlier in more detail. And then also, if you're interested in learning about the firm framework, and ways in which we have been thinking about at Stanford about these open source tools and other methods for evaluating healthcare tools and healthcare AI in a healthcare system, I'll leave you with those two papers. But
brilliant. Thank you so much, Artem. That was a fantastic talk. We might take questions at the end in our panel discussion, but maybe it's a good reminder to everybody that if you'd like to pop your questions in the Q&A, that'd be great. We can answer them afterwards. I'll now hand back over to Dr. Lee to introduce our next speaker.
Okay, thanks for that. So our next speaker is Dr. Wisit Cheungpasitporn. He's leading AI innovation in nephrology and a professor of medicine at the Mayo Clinic in Rochester, Minnesota. He serves as AI content lead for the Mayo Clinic School of Medicine and a course director. So he defines the standards of integrating artificial intelligence and machine learning into the medical education system and kidney health. And I hope he'll share his experience and vision on how AI can improve kidney transplantation.
All right. Thank you so much for having me, and thank you for a really kind introduction. So in the next 15 minutes, I'm going to talk about AI application in kidney transplantation. So the topic is very broad, but I will do my best to give like the practical points as possible in the next 15 minutes. So The contents are all from my own. I need to disclose that I use Claude to help assist my PowerPoint presentation. And AI tools they show in my slides are not my endorsement, and everyone need to follow your hospital AI policy for ethical and responsible use of AI. So we are living in the exciting time, as you know, we have like many innovations in kidney transplantation, like xenotransplantation, organ perfusion, and of course, we're going to go over AI in kidney transplantation together. So the trajectory is clear that we started from like traditional prediction models towards the multimodal AI prediction. And this is already the developed and mature. I'll give you example of the one of the machine learning models that the already mature and ready for FDA qualification review, which is iBox, the AI machine learning prediction model of allograft failure that developed by Professor Lupi and the Paris Transplant Group. So congratulate them for that. And to talk about AI across the transplant journey, AI can help with the referral process, like the candidate evaluation, can help with organ allocation, such as the donor and recipient matching, can help with, of course, like a lot of research and many papers that publish about using AI and computer vision for transplant, the biopsy pathology. And we already talked a little bit about graph prediction, such as the prediction for delay graph function, allograft failure, ambient AI documentation, as well as using AI agent to help coordinate care on the follow-up care. So talking about AI, I'm going to talk about machine learning, which Artem already mentioned a little bit, which is a subset of AI that use advanced algorithm to detect patterns in the large data set, right? So talking about machine learning, you can divide into the three big umbrella, which is like supervised learning, unsupervised learning, and reinforcement learning. So supervised learning, the thinking about the machine learning that learn from label data to predict the outcomes. So you may see machine learning that predict graph failure, predict delay graph function, predict acute rejection by the supervised learning, such as the neural network or random forest. Those are the supervised learning. Another, the one that also supervised learning, such as using the convolutional neural network to interpret the imaging or pathology data, those also supervised learning. So this example of the machine learning prediction model of delay graph function that just published this year by my colleagues in Mayo Clinic, the Arizona, that developed machine learning model to predict delay graph function with the great performances. And this is the one of the supervised example of supervised learning. And this model currently undergoing the evaluation process for implementation at Mayo Clinic, Arizona. So I would say that machine learning prediction model for the transplant, the already ready, already developed and validated, such as the iBox, the machine learning model. And to say that prediction is not the end of the AI implementation, right? It's the beginning that you develop the machine learning model prediction. I'll give you example of this randomized control trial, Prima AI, that just published this year in NTJ Digital Medicine. Charité team in Berlin developed the machine learning prediction model for allograft loss in 1 year, and they implemented into electronic health record in the separate tab. They randomized into intervention group, which is the group that transplant nephrologists able to access to machine learning model prediction, and those that do not have the machine learning prediction model. And you can see that machine learning model predict allograft loss in 1 year pretty well with the great performance with the AU RC of 0.9, but it's not really changing the outcome of conversations between patient and transplant nephrologist on the treatment options after the graft loss. So this is the problem that, okay, you have the prediction model that helping you to predict the graft loss, which is very well prediction, but it's not really the change the outcome. Only the 29% of the transplant nephrologists use the tool, which is in the different tab, and only one transplant nephrologist that use 100%. And you can see that this is not changing the outcome. So we need to think about after the prediction, what should we do next? We need to think the implementation science, right? Develop the protocol or workflow that what we should do right after the prediction. So now I'm going to touch on unsupervised learning so everyone can think about the future project to, advance the kidney transplant together. Unsupervised learning are machine learning model that train on unlabeled data in order to identify the distinct phenotypes and understand about the patient population or the pathology better. One of the common approach for unsupervised learning is cluster analysis. For example, we utilize unsupervised learning cluster analysis into the U.S. Kidney transplant African American recipients to understand more about the patient populations in order to improve their outcomes and improve the equitable care for the African American transplant recipient. This another unsupervised learning that again the Paris transplant group apply unsupervised machine learning clustering approach to understand about transplant glomerulopathy, and they successfully cluster into different the subgroups of transplant glomerulopathy in order to understand transplant glomerulopathy better by AI. So another part of machine learning is the reinforcement learning. Reinforcement learning is the emerging and powerful is a model that agent learns by the acting, observing, and being rewarded. A lot of studies the being done on the reinforcement learning on immunosuppression management, how to adjust immunosuppression management, and they are very great proof of concept. However, reinforcement learning currently not really the implemented in the real clinical practice in transplantation quite yet. The likely going to develop, but taking time. Due to the no safety, the evaluation yet, and also regulation of reinforcement learning still evolving as well. So I'm coming to the exciting and more familiar the topic that everyone use, which is large language model and generative AI, right? Thinking about the model that learn from large amount of text in order to predict the you know the next words or sentences or generate the new content. So the many studies and also like implementation, many centers already implemented large language model into the care for kidney transplantation, including patient education. And I use that the often to identify and to translate the complex, the medical terminology in nephrology and in kidney transplantation to the patients to understand this terminology. Like for example, what transplant glomerulopathy means, what the BK nephropathy mean, and also large language model have the emerging role in multilingual translation and documentation already been implemented. Of course, we need to be careful about hallucination. Everyone hear about this terminology that large language model generate the incorrect and fabricated the information, but sound very plausible. So we human, we have expertise. We need to make sure that human is in the loop and human is oversighting, right? So But how to reduce the hallucination? We use several approaches that we can reduce hallucination, such as prompt engineering or chain of thought is one of them. You can fine-tune model to specific use for your kidney transplant patient, or you can use the technique that called retrieval augmented generation, that you retrieve the information, and the model can give you the information that up to date or the relevant. For example, open evidence is one of example of the large language model that the fine-tune and use retrieval augmented generation that get the output with the citation, and you can look into the primary source to confirm the accuracy. So large language model already implemented in electronic health record, in medicine, in nephrology, in transplant nephrology, to help draft the patient reply and communication with our patient. So it can be outside electronic health record as well. For example, at Mayo Clinic, we use the enterprise version of GPT and also enterprise copilot to the follow our AI policy and the to help with the clinical use outside the electronic health record. Of course, this is not the with all the institution, and you need to follow the hospital AI policy of your own. So, but we are very clear about responsible use of AI, that we do not put the PHI data into the public AI due to the patient privacy. And not only that, we need to think about, like, when we use AI, the where the AI run, right? If you use AI in the EU and data being the move or transfer to the AI in the US, then that's not gonna work, and that's not gonna follow the EU AI Act. So another possibility that your hospital can think about is, like, how's your AI policy in the hospital? Can you use the local AI gateway that running AI at your institution? So ambient AI, we already implemented in nephrology and transplant nephrology, thinking about AI that listening to your conversation, right, between you and your patient, and you record the conversation, and Artem is the emphasize the importance of consent for ambient AI use, and then the after the conversation, voice turn to text, text going to the large language model, and you have the documentation for you to ready and review and sign. But again, the responsibility, the ownership of the note is your own, so you need to make sure that you review them and you ensure the accuracy of the note. AI agent, the being the more popular and emerging into the care for the medicine as well as the transplantation. So thinking about not only the AI chatbot that just answer your questions, but AI that can understand your goal and taking action, the such as like collaborate the care, which is the AI agent. So we launching campaigns for AI agents in our institutions. There are many AI agents that are being developed and implemented currently. One of the idea that you can use, which is using AI agent to help coordinate care for your transplant patients. For example, this campaign is from Mayo Clinic, Florida, that use the AI agent to help with the transplant nurse that really the overload in the work. So in the next few slides, I'm gonna say that I cannot go over all of them because of the timing, but you can use AI for other the aspects of the kidney transplant care. And for example, allocation, there are some vendors that develop the AI model and machine learning model to help accept or discard decision. But the to implement the worldwide or more the like widespread is a little bit the more challenging, because as you know, this machine learning model, there are some black box that and also model can work for some other patients, but not all patients. So you need to think about equity, bias, and transparency as well. So for matching, for sure, in the future vision, AI will help with the more granular matching for molecular HLA matching and emerging AI integration, such as like applet mismatch, for example. And I need another hour to talk about digital pathology, but as you know, that CNN and computational the power can now the doing classification and segmentation and identifying the kidney pathology lesion in order to like quantitate if the helping with the band classification the stores that we currently have. And last slide on this would be the technology is not only AI, right? You're thinking about like now we have donor-derived cell-free DNA, we have like MMDX gene expressions, those like omics that help integrate into the machine learning model and AI model in order to develop the multimodal, the AI integration model. And we are in the exciting time into the precision, the medicine and precision care for kidney transplantation. And again, I want to emphasize we need to think about equitable, explainable of those black box model, and also thinking about data privacy, where the AI run, and patient consent as well. Thank you for having me.
Thank you, Wisit. Just before we move on, are you able just to tell us and define a little bit? We hear a lot about prompt engineering, and you mentioned it. What exactly is prompt engineering?
Yes. So the in order to like the improve or get the great output of the model of the large language model, right? You have prompt engineering. Prompt is how you give the instruction, how you ask the large language model, right? The there are the several approaches you may hear about zero shot prompting, like you give like one the brief the question. You may hear about the chain of thought prompting, which is I use that a lot to like please help the doing this, explaining this, the step by step, for example. And then the model not only giving you output, but also giving you the like the reasoning, like why they're giving you those output. So how to ask the model or prompt engineering is another approach to reduce hallucination, and it's good the like knowledge skill that everyone should learn. And also to the improve the model output, like accuracy, not only prompt engineer, right? We talk about fine tuning, we talk about retrieval augmented generation, but also there are some emerging ideas such as like context engineering, that you also providing the model more or specific context that the model should learn. So that is also another part, like context engineering. You may want to learn about that. And also like the memory, like how to create the memory to the model. And also like, the tools that models can call, and, the connect to those tools in order to give you the answer. And
Mhm.
also there are many more techniques, but I don't want
Mhm.
to just like the giving you idea that everyone who like the excited and the about this, they a lot to learn and to do research on this the to advance the care for our kidney transplant together.
Mhm. And we might come back to you in the Q&A session. Harry, hand over back to you.
Cool. Thank you. Our final speaker for today's webinar is Dr. Mamatha Bhat. Dr. Bhat is a transplant hepatologist, a co-lead of the Transplant AI Initiative, University Health Network's Ajmara Transplant Center. She's also an associate professor at the University of Toronto in Canada. And we're really excited. Today she'll share with us how AI has been leveraged to improve clinical management in liver transplantation. Thank you so much.
Okay, great. Well, thank you so much for the kind introduction. And I'd like to thank the organizers for the invitation to present today. Really exciting to see the diversity of work across transplant. I lead a highly interdisciplinary research program and enthusiastic research team of computer science postdoctoral fellows and graduate students, and also working closely with clinical research fellows. So excited to present some of that work as well as share the overall landscape of AI and liver transplantation. These are my disclosures. So first of all, how can AI benefit liver transplantation? And then I'll get through steps along the transplant journey as well as limitations in liver transplant medicine and transplant overall. So overall, the inspiration for AI and transplant is that we are taking care of a complex patient population, lots of different variables, including longitudinal changes in those variables that then provide us with some insight and intuition as to what should be the best care for our individual patient. Now, the human brain can only account for 7 variables at a time, notwithstanding longitudinal changes in those parameters. So this is where AI can be helpful as a co-pilot. Additionally, as a transplant physician, I think there's a great deal of potential to bring objectivity to the complex decisions that we make along the liver transplant and transplant journey overall. So first of all, I'll cover candidacy selection. So this was the inspiration for a project that I'll present to you. Transplant selection is determined by a multidisciplinary selection committee, but the process is vastly understudied and prone to different issues, including inconsistencies, center-specific rules, group dynamics, biases, including recency bias, and unshared information. So we worked on a project that was published online in 2024. This was basically, we built a multi-agentic committee that wherein we had an AI agent representing each of the expertise on the transplant selection committee. And we prompted within GPT-4 assumption of domain expertise. So we had an AI hepatologist, AI transplant surgeon, social worker, and cardiologist at the time to review over 8,400 cases that we had generated using data from the US Scientific Registry of Transplant Recipients. So clinical vignettes were generated using an AI medical scribe. And we determined that in this proof of concept study, we determined that the multi-agentic transplant selection committee could accurately identify those patients who would derive a 1-year survival benefit with an accuracy of 92%. So this was published in Lancet Digital Health a few months ago. Additionally, we looked at the characteristics that accounted for each agent's decision. So it was very reassuring to see that the features of the clinical vignette each of these agents focused on really made sense from a clinical perspective, as you can see here. So we have now been implementing this multi-agentic framework, having added on a psychiatrist and a anesthesiologist as well to then review the PowerPoint presentations that we present to advocate for our patients since last August 2025 at our institution, so at the University Health Network. And basically you can determine how each AI agent would review that clinical vignette and all of the tests that have been performed to then provide an accept versus decline decision, as well as the rationale behind that. And we have been implementing this since last August at UHN as shown here. So we have reviewed several patients with this particular multi-agentic system and determined over 80% concordance with the human committee. Admittedly, we are also working to further train this multi-agentic committee based on past historical outcomes of the patients we have accepted versus declined for transplant. We are also now engaged in an international silent trial. So Mayo Clinic and UCSF have initiated the silent trial at their sites. We also have NUHS in Singapore and Medanta in India, as well as Mass Institution Massachusetts Institute of Technology. So all of these are partners in our prospective silent trial, and we also have a pre and post intervention design study that is set to commence in 2 months' time, so which is very exciting for us. And it's really towards the goal of more objective and consistent decision making in transplant. Then I'll move on to waitlist prioritization and organ allocation. So there are disparities in liver transplant prioritization that are known historically, and this is because there's been difficulty in modeling a highly heterogeneous population. So over time, we've determined a disadvantage to female patients. The MEL 3.0 score tries to address that, but doesn't fully rectify it. There's a disadvantage to patients for whom the bilirubin is the main representation of how ill they are. As well, there are various other issues, dynamics and shifts in the underlying cohort, as well as liver cancer accounting for a significant proportion of the waitlist, where the tumor biology actually dictates their risk of dropout and survival, as opposed to decompensated cirrhosis. So lots of heterogeneity on the waitlist, and it's very difficult to model this if one is considering just a linear score. So Gemma AI, which was developed in Spain, actually seeks to address this and uses an explainable neural network to transition from a linear to a nonlinear score. And in fact, the authors determined that it resulted in differential prioritization of 6.4% of patients within the first 90 days. Herein, they accounted for female sex, as well as additional parameters, including GFR changes over time. So they accounted to some degree for dynamics, which was very exciting, and they have implemented this tool for their prioritization of patients, which is excellent to see. And now, additionally, we must be able to then account for various other considerations, as I mentioned. So we also have ongoing work that seeks to address various other features that one would consider. So this was a deep serve model that we developed to account for both velocity and acceleration, as well as additional variables such as PBC, PSC as indications for transplant. And with this particular approach, we achieve a concordance index, a 90-day concordance index that is significantly higher, statistically speaking, than the MEL 3.0. We then can look at subgroups. I don't show this data, but basically PBC and women have a particular advantage with our model. And with Shapley analysis, we can identify what are the key features that are driving that prediction. So reassuringly, we see that the key features that comprise the MEL 3.0 are the key drivers of risk. So this is very reassuring because those are also found in the MEL 3.0. But however, there are many patients for whom other variables, including the velocity of blood test results over time, are quite important. And so what this tells us is that the MEL 3.0 is insufficient to account for the heterogeneity of several subgroups of patients on the wait list. And so we can do much better with newer models. And so here you can see individualized interpretations of dynamic trajectories for this particular 50-year-old woman with PBC, for whom the fact that she has PBC initially is the dominant driver of her risk, but then later on the wait list, the fact that she's just started dialysis is the most important indicator. And this fits with our clinical intuition as well. This is an integration of our model into EPIC, which is our electronic medical record system, really courtesy of our data engineer who was able to implement the solution, enable automated pull of the data to then feed the dashboard and provide individualized predictions with our Dynamel score. And you can see how the patient does dynamically over time, as well as relative to various other patients on the wait list. So you can see that as well, their survival benefit and the Shapley analysis showing which are the key factors that are driving that patient's risk at that particular point in time. I should also mention an excellent model that has been recently published by a group from Stanford, wherein they developed a light GBM model, so a gradient boosting model that had an excellent AUC to predict futile procurements of DCD organs in liver transplantation, really a multi-center effort, including implementation. And they also determined that this would result in lower futile procurement rates compared to surgeon predictions. So really excellent work that has come out of this multi-center study. So finally, I'll conclude with personalizing post-transplant care, and I'll just mention a few studies that we've published last year in Journal of Hepatology, also as a way of demonstrating how we might leverage observational data in transplant. So you can simulate clinical trials. This is a particular new method that we published to leverage observational data, comparing the survival benefit of living versus deceased donor liver transplant. And I invite you to look at the specific methodology, but basically we did some matching based on several clinical variables of interest to then look at the trajectories and survival benefit of certain patients over time, including also the Shapley analysis, so the modifiable factors that would account for the survival benefit. We also have this particular model, which is a CV risk prediction model to predict the risk of cardiovascular events post-liver transplant, which we actually implemented in the clinic and demonstrated a 52% modification in the behavior of physicians to then modify and optimize cardiovascular risk among our liver transplant recipients. So just an example, and this is in final revisions in Lancet Digital Health. We also have this model, which we published last year as a multi-center international effort, multi-class artificial neural network for multi-class diagnosis of graft pathology, which overall worked quite well with an AUC of 0.866, but we realized that it didn't work so well for diagnosis of rejection. In fact, we then brought the human in the loop to teach the model further because the clinicians were recognizing certain cases that the AI model was unable to recognize. So we brought the human in the loop to further teach the model, which resulted in increased performance, as you can see in the table on the right. And then finally, we determined generalizability of this model across international sites, including at Mayo Clinic, Hanover in Germany, and NUHS in Singapore. So interesting demonstration of generalizability internationally. So finally, I'll conclude by just stating some limitations and happy for us to discuss this further. There are various considerations, particularly in transplant, where we are dealing with smaller data sets at each institution. So certainly there's an interest and importance in having multi-center studies, so to demonstrate generalizability. There can be biases in our training data quality issues. So really it's based on what kind of data has been entered by clinicians over time. I would propose that we need better explainability and prospective evidence to really demonstrate clear benefit and safety of these solutions over time. There's also human factors that clearly we need to consider. So there can be alert fatigue, and there needs to be very seamless integration into the workflow to permit deployment to ensure the best possible care for our patients. So in summary, we take care of a very complex patient population, but lots of opportunity for AI tools to leverage dynamics and longitudinal data to provide more personalized care and objective care to our patients. Really, the next steps are integration into workflows, continual learning, and responsible deployment. I'd like to acknowledge my research team and collaborators internationally and our funding sources, particularly the CIHR, where we have a very nice national project involving all our Canadian liver transplant centers. So 3 key projects supported by CIHR nationally. And I'd like to invite everyone to attend our Transplant AI Symposium, co-organized with Mayo Clinic. So we've been holding this Transplant AI Symposium for 3 years now in Toronto, and our last one was in November 2025. Our next one will be co-organized and led by Mayo Clinic this time in January of 2027. So just putting in a plug for that, and happy to take questions. Thanks so much.
Amazing. Thank you so much for that. That was a fantastic talk.
Thank you.
And sounds like it's going to be a great conference in January. I might now open up to Q&A for all of our panelists. So Again, if you haven't had the opportunity to put a question in the Q&A, you can do so now. But I might open up with a question from Kevin in the chat, who thanks, Kevin Fowler. It's good to see you again. We've got two questions, and I might kind of just ask them interwoven, and whoever feels as though they've got answer can kind of go first. But Kevin's two questions are both around where the patient fits in this. And so the first question is basically, yeah, are there any projects that are focused on improving patient quality of life post-kidney transplant? And the second one is around how are we using AI to meet the priority needs of transplant patients and ensuring, and I think this is actually a really good question, that the physician relationship is strengthened and not diminished. Again, whoever feels ready is more than welcome.
All right, may I answer
Sure, yes,
those
of course,
questions
Wisit.
first, and then everybody else can help join. So the very great question, the Kevin. So, and I agree with you that the patient quality of life and patient should be the like prioritized into like this like what AI models, what AI projects that we need, because ultimately we want to improve the patient outcome. And a lot of studies of course that been developed and integrated are for like improving the process, as you see, from the patient selection through the coordinate care, like predict the allograft outcome. I agree with you that the ultimately we need to think about like quality of life for the patient, how patient feels, and overall patient satisfaction. So there are some data so for example I'm going to put into the references into this. So basically the AI that being used for helping patient quality of life, for example, like if you say like dietary advice is also like quality of life, there are some studies that using AI to help guide what they should eat, for the kidney patient, and also include the patient kidney transplant population, that what they should avoid if they have like high potassium or high phosphorus or modified dietary to improve quality of life. There are also studies that the evaluated quality of life as a secondary outcome, is not the primary outcome. For example, to help guide with immunosuppression management, and that study that I put the reference showing that patients who have the AI integrated to help guide and coordinate about immunosuppression management care have the better quality of life, so they don't need to like have a lot of like the challenges or like complex the conversation that they need to call transplant center, communicate with transplant coordinators, like how and what they should do to get the tacrolimus level, to get the tacrolimus dose adjustment. And that is sometimes it's frustrating for the patient to waiting for the what they should do for the next dose of immunosuppression. So there are some studies that evaluated quality of life of the patient, but not as a primary outcome. And I completely agree with you that we should get the patients and patient advocate the at the beginning to the develop the AI or technology or application that really help improve quality of life for the patient.
So
Okay. I can perhaps add. Oh,
go ahead.
sorry. Yeah, I can add on to that. So that's an excellent question. In fact, we have patient partners as co-applicants on our grants. And they really have inspired the work we've done in my group. Certainly, we have regular updates and feedback meetings with our patient partners at the Canadian Donation and Transplant Research Program. I would say overall, as transplant physicians, it's very important to have your clinical work and clinical problems inspire the research that we do involving AI. So I would say that the key problems that I've been working on, and certainly I think many others have been working on, are really inspired by that experience. But I completely agree. It's very important for us to consider what resonates, what is most important to our patient partners, and really work on those problems in collaboration with them. I think that makes our research much more meaningful in the end.
And to wrap on that, so the patient perspective has always been an important component, and the process that I outlined in my talk, we really value the patient perspective, and so they are involved in our assessments from the beginning before a tool is turned on. I think that is a super useful and important part of a voice that is to be included, so that way we can make decisions when we're deciding whether or not to turn on or turn off a tool.
Yeah, that's great. Thank you for answering that. And it's a great question from Kevin as well. He's always advocating for better patient involvement and consumer involvement. Is there much patient, I guess to the panel, there's a lot of work on frameworks, at least, and ways to try and have good ways of integrating clinical AI into clinical use. And I think you're involved in the ASN version. I've seen some publication from the Europeans as well. I guess there's different outputs about AI and clinical use from different societies. Is there a push or any appetite to work together across societies to come up with a unified guide, framework or guidance to do this? Because I mean, otherwise you'll have fragmented care. And is there much patient involvement in those frameworks you guys have been involved in?
Yeah, so I'm chair of the American Society of Transplant AI Task Force, and we are working to publish that guidance very soon. I can't give you the exact timeline, but we do have this task force set up as of last December. So working hard to get some guidance out there for transplantation overall, at least through the American Society of Transplant.
Yeah. Is there any talk between the societies, or even if it's not transplant, like across a little bit more a unified approach? Because otherwise you'll have like different recommendations everywhere.
Yeah, good question. I'm not really involved in the governance and I'm involved in the governance for the task force itself, but admittedly, I've not looked into cross collaboration, and that's an important question. It's something I should bring up with the AST, because I think that would be an excellent way to, say, harmonize. Internationally. Yeah.
I I completely agree with Dr. Bhat, and very great point, Dr. Lee. So as you may already know, ASN published our statement for AI in kidney care, and include the part of the kidney transplantation in JSON earlier this year. But I agree with you that we need to the integrate and collaborate many organizations together, and also for example, like KDIGO just had the AI and technology, the controversial the meeting in Spain last year, and the statement is being developed, and hopefully the will be the published soon, and that will also involve some of the kidney transplantation part. And also the in that the meeting, as you know, KDIGO also like invited and include the patient advocate. So then that would answer the question for Kevin about, like, when we doing this statement, and we the thinking about the AI and technology for patient, we should get the patient involved, and that is the idea. Ultimately, the 2 points that I want to raise is we should have like federate learning, like the idea of another topic that we did not mention, which is federated learning, thinking about like the model that the because different countries have the data privacy protection, and in order to develop the global model, then we should collaborate, and then instead of like the data that moving to the central processing center, the model being trained in different center and then calibrate, and then you get like the global model. So federated learning, federated the collaboration is something that I would love to see more in the future. And also another thing is like also with the emerging technologies of large language model, and also like the agentic AI workflow, that in the future very likely that you think about like agentic AI that have multiple guidelines, that have different opinions, different consensus, and all together summarized as a multiple the integration by AI agent. Thank you.
Great. Thank you everybody for all your input and sharing all your expertise for this. And we've come to the end of the hour, so I do have to try and wrap this up. So thank you to the panelists and the speakers. Thank you to the audience who've turned up and asked a few questions today. So just to plug that the TTS, the Transplant Society Congress 2026 is happening in Sydney in September. If you haven't already registered, this is your opportunity before it closes. And it'd be great to see you in Sydney. It's going to be good weather, good chance for a holiday, and also to learn some transplant related topics. And yeah, hopefully I'll see you there. All right. Thank you, everybody.
Thanks, everyone.
Okay. Thank you.
Thank you. Bye.
Thanks so much.
Bye.
That was excellent. Thank you.